Good morning, everybody. Welcome to class. We have a very short amount of time together. Thank you. Thank you. Um, so today we're going to continue our discussion on medication administration and management. You guys can hear me okay, correct? Before I continue.
Yes. Yep.
Thank you very much. All right. So we'll be reviewing, as I know you saw from your PowerPoints, and you're reading. We're going to be reviewing the 12 rights of medication administration, protocols around the administration of narcotics, nurses' responsibility in reporting medication errors, the importance of medication reconciliation. And at the end, we'll be watching a video. This video is actually going to be 8 minutes long. I thought it was an excellent example of the things that we're going to be talking about. I'm really interested in your feedback. And then, of course, we'll end with some questions. So we only have about 50 minutes. So we don't have a lot of time because I want to give you a 10-minute break. So we should be ending around 10:10, and then you'll have 10 minutes before your next lecture. So please make sure your microphones are off and refrain from the sidebar comments. And we're just going to jump in and get going. All right, so obviously the concept is safety, the minimization of factors and errors of commission and omission that can cause harm to patient, self, or others, or delay patient recovery through individual, unit, or system performance. We talked about this during our last lecture, and the importance of safety and everything that we've been doing to promote safety in the healthcare systems for the protection of course, the patients and obviously ourselves, and the importance of making sure that when these evidence-based practices are delivered to you, like the 6 rights of medication, or and today we'll be talking about the 12 rights, that you actually deliver them, that you understand that these practices are put in place for the safety of all. So on that note, I just want to mention too, commission means doing something wrong, and omission means failing to do the right thing. All right, so the 12 rights of medication, I don't know if you were aware that there are 12 rights. We're always talking about the 6 rights, and that's because they developed the 6 rights, and like anything else, we continue try to building on the safety of our practice. So you can imagine that the right reason, the right assessment, the right response, obviously those are all things that you're doing anyway, but you've been in practice being asked to talk about and pass your medication with the 6 rights. So I'm just going to kind of review these a little bit, a little quickly. It doesn't diminish the importance. I just want to make sure that we review them. So again, the right medication, you know that you guys are comparing medication label to the MAR 3 times. And that's important, that number 3 times. There's a reason that we do it 3 times. Right patient, you're validating the 2 identifiers, the name and date of birth, the right time. You can give medications, just so you know, an hour before or after. That would not be considered an error unless there's a specific medication that they are absolutely saying you have to give this at that time. The right route, example, subcutaneous versus, so for example, the right route is important. And I'm going to go back to those 3 checks, because I recently almost made a medication error, but the 3rd check saved me, which is why it's important that you do this. So I had a patient that was getting IV morphine, and I had been there the night before, and every 6 hours I was giving the IV morphine, and for whatever reason, and I don't know why, they changed it to sub-Q morphine. So I pulled the medication. I didn't notice the route. I looked at the MAR, I didn't notice the route. I pulled the medication, I didn't notice the route. I'm at the patient's bedside. I'm literally scrubbing the hub. I'm about to give this medication, and I look at my MAR for my last check, and I realized that this medication was actually changed to sub-Q. So I would have missed that. So make sure that again, just to remind you that complacency in practice obviously is an issue, and we talked about that last time. So make sure that you understand that there's a reason we're doing those 3 checks. The right documentation, of course, we talked about that. The right route, the right dose, the right drug and time. Right education, so informing the patient of side effects. I think I mentioned the last time that one of the policies that we have on our unit is that when I'm administering medication to my patient, I have to give the side effect to at least one of the medications. I think it's good practice. So I might say to them, I'm giving you this, this, and this. I'm giving you metoprolol. And remember, some of the side effects from metoprolol is it can be causing some lightheadedness or dizziness. So please let me know if you're experiencing any of those. So education, if you're introducing a new antibiotic, you certainly want to educate the patient on why they're getting it and what side effects they might have. The right reason. So you want to confirm the rationale of the order. So why the patient's getting this medication. You need to know why that is. So a doctor might put in an order for something. We don't blindly just give medications, right? Because we know that doctors make errors as well. And there's a reason why we all do our checks. And I'll give you an example of that. Last year, there was a patient the nurse got the patient, and the order was to start a heparin drip, which obviously you know is a high alert medication. So they wanted to start a heparin drip on this patient. The nurse saw the order. She acknowledged the order. She drew the PTT. She did everything correctly up to that point, and she started this IV heparin drip on this patient. She gave a report to the next shift nurse, which was at 3 o'clock. Again, gave the information. They went in and they did the handoff on the heparin drip. When's the next PPT being drawn? 11 o'clock, new nurse gets the patient. Same thing, gets report, 7 a.m. Next nurse gets report, does the safety check, and then the patient starts complaining, why am I on this? Can I just take this off? So ask questions at that point, and the question was the patient had actually come into the floor for alcohol withdrawal. So the question would have been, why would this patient be on a heparin drip? Remember, it's an anticoagulant. We usually give that to somebody who is maybe in AFib or has a clot. So at the end of the day, the nurse texted the doctor and said, look, this patient's really saying that they don't want this heparin drip. What can we do? And immediately there was a stop order on that heparin drip. The order was given to the wrong patient, and the patient down the hall was supposed to be started on a heparin drip for a blood clot that they had. So many things wrong there. The doctor made the order, placed the order on the wrong patient. The nurse didn't catch it because she didn't ask the right reason. She just blindly gave this and didn't ask, well, why am I giving this medication? The next nurse didn't ask why. The next nurse didn't ask why. And then the patient that was supposed to get the heparin drip, of course, was at high risk. So, again, we go back to complacency and the reason why we have the 6 and 12 rights. Right response. So when you're giving a medication, does it have the desired effect? So if you're giving a pain medication to a patient and the patient's telling you that their pain is 8 out of 10, and you reevaluate an hour later and the patient's saying my pain is still an 8, it's not having the desired effect. So you have to be aware of that. Right reaction. So obviously we're confirming allergies. And of course the patient always has the right to refuse. Sorry, I need to get some water. So I know that was a quick review, but I hope it just reemphasizes to you the importance of making sure that you do these 12 rights of medication administration. Okay. All right, so narcotic control system, we talked last week about the Pyxis and the importance of technology in our practice and how it's making us a little safer. So you're going to identify that the order was you're going to identify the order. So let's say in the Pyxis, you see that the patient is scheduled for Q6-hour oxycodone for pain. You, of course, are going to assess the patient for the pain prior to giving the medication. Even though it's scheduled, you're going to ask them where their pain is. You're going to ask them, is it aching? Is it sharp? Does it radiate? You want to make sure that you're assessing that. You're going to then confirm in the MAR when the last time that was given, because if it's Q6 hours scheduled, but perhaps maybe somebody gave it late, you need to make sure that you are giving the patient it at the right time, especially when it's scheduled a narcotic. You then go to the Pyxis and you go to withdraw the medication. The Pyxis is going to open the drawer and it's going to ask you to count the medication that's in the drawer. Obviously, that's a safety reason. obviously people were taking narcotics, stealing narcotics in the past. So you need to make sure that we have the right count. So it'll say count the narcotics. You're going to count the oxycodone, for example, and let's say there's 22. If you put in 22 and in actuality there's only 21, it's going to ask you to recount. For some reason, I always miss my count. I think it's because I have it in my hand and I don't count that one. So then you recount it and you put that in and it will accept it. And you close the door and then you have your narcotic. If it's something like a morphine that is a liquid form, you would have to have a second nurse, which again is the protection of you and the patient. Make sure you do that. And you have a waste. So let's say you have to waste like 0.5 mLs of this. The nurse is next to you is going to be there. She's going to see that you pull that and that you wasted it. She's going to watch you dispense it. And she's actually going to sign off on that. And obviously a pharmacist or a doctor can do that as well. And again, make sure, like I said to you about my almost error with my morphine, make sure that it's going into the right route. And then of course you're going to document the patient's pain rating before and after you administer the medication. So that is a typical evidence-based practice that is in place for dispensing any kind of narcotic. This was not in your book, but I wanted to make sure that this is something that you're aware of. I consider it very important, so I would lock onto this slide. I made a medication error my first week as a new grad because I didn't know anything about this scale. But it is actually wrenched into every MAR, and perhaps maybe some hospitals don't have it, but in all likelihood, they're all there under the pain scale. So this is called the Placebo-induced sedation scale. So if you're passing out narcotics, so basically it's a valid tool used to assess sedation when administering opiate medications, and it's to manage somebody's pain. If you're managing somebody's pain and they're getting scheduled, or they're getting, even if it's like a first-time dose of pain medication. So this scale is used, and you look at the scale prior to administering the medication. So for example, I had a patient my first week and they told me that he was very grumpy and he was very cantankerous and he always wanted, and you had to give him his pain medication exactly on time. And don't forget to do that because he's going to get really mad. And of course, I'm a new grad and I'm already feeling like I'm behind in my meds. So I go down to give this person his, I'm not sure, I don't remember what it was. It was probably oxycodone, to give him his pain medication, and he's asleep. And I don't know what to do because I think he has to have it and he's going to be mad and it's a problem. So I wake him up. And I do wake him up and he's like, yeah, give me my pain medication. Blah, blah, blah. So I give it to him. And then I do come back an hour later because I am still new and I'm trying to be a good nurse, and I can't wake him up. And I notice his respirations are low, like 10. So I have to call a rapid response. Well, I don't call a rapid response. I still don't know what I'm really doing. I'm nervous. I grab the charge nurse. We call it rapid response. Had I done this scale, had I recognized that this patient was too drowsy for this medication, I would have held the medication, regardless of how mad he might be. This medication would have saved a sentinel event, a safety event, and I could have really harmed this patient. So this is really important to know. For the sake of our discussion, and I would say for the exam, you should know what happens and what you should do for all of these. But just so you know, there is a scale attached to your MAR. And when in doubt, you should always hold and, certainly ask somebody. But this is a guidance for you. So if the patient's sleepy but easy to arouse, you can give the medication. If he's awake and alert, give the medication. If he's slightly drowsy, easily aroused, you can again give the patient the medication. And if they're complaining of continued more pain, you can certainly give more of a dose. But however, if the patient, like in my case, it was very drowsy, he was arousable, like I was able to wake him up, but he's kind of drifting off to sleep during the medication, I'm going to hold the medication. I'm going to monitor his respiratory status and his sedation level, his level of consciousness. I'm going to let the doctor know that I have held that medication. And obviously, if he's somnolent, no response to verbal stimulation, I'm going to probably call a rapid response and and definitely not hold that medication. So I just want to make sure that you are aware of that. Okay. Um, so factors contributing to medication errors. So omitting one of the rights of drug administration. Obviously, we've all been impacted by this. I know that this is going to stick with you. Failing to account for the patient variables such as age, body size, impairment of kidney or liver function. A lot of my older adults are on Tylenol, but there's a certain amount you can give in 24 hours. And obviously we want to make sure that I'm not overdosing my patient. Kidneys help get rid of wastes, so it can build up. Those certain kind of drugs can build up. Same thing with your liver. That acts as a filter system as well. So overdose on, for example, something like Tylenol can cause liver toxicity. So you want to make sure that you're aware that there is a difference between an older adult, a child. Okay, there's different doses, and medication should not be just given straight across the board. Giving medications based on verbal orders or phone orders, I don't do that. I do like to text the doctor if I have it in writing. So, for example, I had a patient the other morning who had a high blood pressure, and it was 6 a.m. and he had a 9 a.m. metoprolol. I wanted to give it. I knew there was no problem with me giving it. However, I made sure that I texted the doctor and said, vital signs are this. I would like to give the 9 a.m. Metoprolol. Would that be okay? And then he said yes. And now I have that, on text on my phone. Practicing working under stressful working conditions. Obviously, we know this. We've talked about this. You're going to be walking into this. There's no way out of it. You are going to be walking into a nursing shortage. You're going to be under stressful conditions because you're a new grad. All of these medication rights and management, these are all there for the protection of the patient and yourself. And working under stressful conditions is definitely going to be something that you're going to be encountering. I just want to say this real quick. I'm a little disappointed in our time. I just want to give you an example of something that happened to me last night, the 2 nights ago. I came in and I picked up a patient at 11 o'clock. The nurse who had him had 5 patients. She had no Clintech all day. And the 3 patients that she had were actively stooling like every hour. So when I walked in and looked up the patient, I recognized that the patient did not have his vital signs taken since 2 o'clock. He had a cardiac monitor on him. So he actually should have gotten his vital signs taken at 6, and he should have had his vital signs taken at 10. She was under a great deal of stress. She could not have been nicer. She was working with no Clintech. She had more patients than anyone else on the unit for some reason, and she had gotten an admission. She went in to help me clean him up, and he had been getting enemas all day, and he just had liquid stool everywhere. So he's lost a lot of stool. He was oriented ×4. I assessed that while I cleaned him up. And then when we were done, I took his blood pressure, and his blood pressure was 72/45. So that was a failure really of the system. She had 5 patients. She had no Clintech. She did not take the vital signs all day. Didn't recognize that they weren't being done. And I had to work from 11 o'clock till 5 o'clock to get his blood pressure up. It took 3 liters of fluids, and it finally went up to 106. So that could just as easily been a med error. So I just want you to be aware that you need to be prepared coming in, because the person before you might be missing things. Being unfamiliar with medication, contraindications, side effects, dosing, and reaction to medications. Obviously, it's important that you know what medication you're giving and what the side effects might be. And if the side effect that the patient is experiencing, then perhaps you need to stop the medication. Obviously, if you're giving an antibiotic and the patient starts becoming an issue in red, you know that that's not a normal reaction to the medication, and you need to stop it. So reporting and documenting medication errors, really important. Nurses' legal and ethical responsibility to report all medication errors. You saw in we talked about Rhonda Vaughn, and she immediately reported that error. We are under obligation to do so. All healthcare facilities should have clear policies and procedures. Remember that systems, they should be protecting you and the patient. Documentation must include the nursing interventions that were implemented to protect patient safety, such as monitoring vital signs and assessing for possible complications. Nurses should document all individuals who are notified of the error, and nurses need to fill out an incident report. So when the error happens, you're going to, of course, report the error. You're going to monitor, depending on what you gave the patient, you're going to monitor what's happening. You're going to obviously notify the provider immediately. Because when you give a medication, let's say you realize that you double dose the patient on metoprolol, and the second it goes down their throat, you're like, oh my God, I just gave them a second dose of that. Normally I say to you, any change of anytime you send something to the doctor, you want to send the vital signs. You would have sent the vital signs that you took just before you gave that dose, but you would immediately notify the provider. That's important to know. The second that you make an error, you should do that. And I will give you an example of, I had a discussion with one of the nurses on the floor. There was a float nurse the other day, and one of your colleagues was, we were asking her a question about insulin. And she had reported that just a couple of years ago, she was new, and she realized that she gave a patient 20 units of I think she said 50, which is even scary. She gave a patient 50 units of short acting insulin when it was actually supposed to be 50 units of long acting insulin. So the second she pushed it, she realized what she did and she panicked. Something happened, and that facility, you are not able to pull insulin without a second nurse verifying her. She did have a mentor that was there, the charge nurse, and she did say to the charge nurse, I'm pulling this insulin. Do you want to come verify with me? And the charge nurse said, no, no, you're fine. Just pull it. So that was the first error. The second error was after she pushed it, she immediately went to the charge nurse and said, I just pushed this. She was absolutely panicking. And the charge nurse directed her to hang a bag of D10. And she called it work, and just give the D10, the patient will be fine. So many things wrong with that that statement. One, we do not have the right to dispense medication. Certainly not say yes, the patient needs D10. Thankfully, this person did the right thing and immediately called the doctor. The doctor responded, said it's okay. Just monitor, give them this and then continue to monitor. So anyway, needed to tell you that. That was a shocking story. And so when you're filling out, so she would have filled out an incident report and she would have had to put in the incident report. I did not verify with another nurse. I reported it directly to the doctor. Any things that might have been contributing to the fact that she made an error, maybe that she's a new grad, maybe she was distracted, maybe they were understaffed. Okay, so make sure that you are doing things correctly, and don't listen to people that are more senior or older. You need to follow safety guidelines. They're there for a reason. Okay, sentinel and patient safety events. So basically, a sentinel event is a patient safety event that results in unexpected, serious, or fatal injury. So, for example, if she had given that 50 units and then the patient ended up becoming so hypoglycemic that they had to call a code, that would have been considered a sentinel event. And honestly, I feel like this should have been a sentinel event anyway, because that's a high alert medication. But if somebody was like in a chair and they got up and they slipped off the chair, that would have been a patient safety event, but there was no serious harm or fatal injury. So it certainly would have been reported. And they certainly would have asked, and you certainly still would have filled out a patient report. And it would have just been, reported, but not necessarily considered a sentinel event. A sentinel event would be something like, for example, a couple weeks ago, there was a patient that was on suicide watch, and there was a clin tech that was with her. And the patient went into the bathroom, and the clin tech let her and shut the door. And after a little while, she didn't hear anything, and the patient had able to lock the door and tried to hang herself by the shower curtain. So that would have been considered a sentinel event. And of course, the whole entire hospital received re-education on that. Something else that would be called a sentinel event is if somebody fell and fractured maybe one of their cervical spine. So any kind of injury due to a fall. If they left an object in a patient, if they did surgery on the wrong part of the body, okay, these would all be considered sentinel events. So I think you should know the difference between the two. All right, so strategies for reducing medical errors. So most common errors are usually administering improper dose, giving the wrong drug, and using the wrong route for medication. Again, if you follow your 6 rights, that is not going to happen. Increased risk for older adults because they often take numerous medications and have more than one healthcare provider. This happens more often than you'd like. So if you have an older adult, more than likely they can have a cardiologist and maybe a pulmonologist, and then they have their primary doctor. So if they have a number of different doctors, or arthritis doctor, they might be getting double prescribed medications. Fortunately, some of the things that we had talked about last week was they've got the medical health record now, where everyone's health record could be in one place. Then they might be able to pick that up a little bit easier. Okay, but older adults with multiple physicians are definitely at higher risk um, for medication error. Children are vulnerable because medications are given based on weight, and we'll talk a little bit about that in a little bit again. So they're very vulnerable because they don't get the same dose, and there's still a lot of studies going on around like what exactly is the dose, and mostly it's going to be based on height and weight. But it would be very easy to overdose a young child, so they're a very vulnerable population. To avoid medication errors and promote self-medication, administrators should follow the steps of the nursing process. All right, so medication reconciliation. So this is important. That's why I highlighted it. So medication reconciliation is the process of tracking medication as the patient proceeds from one healthcare provider to the other. It's the first thing we do when they come into the hospital. It accurately should list all of the medication the patient isn't taking and attempt to reduce duplication. So you don't want to be giving 2 types of medication that are doing the same thing unless they're supposed to go together. Omissions, dosing errors, or drug interactions. So it's very important. It gets done on admission. The pharmacist should be doing it as well if you're lucky enough to have a pharmacist, but you're not always going to work in a place that does have a pharmacist to do that for you. Most hospitals have implemented a process for documenting a complete list, which is true. So I have in my MAR, I have a list of the patient's home medications. I picked up a patient last week who at 11 o'clock, I knew she was there for a week. I was there when she was admitted. She was never my patient. She was violent when she came in. She was anemic. She also had chronic pain and had a pain doctor. And when I came in, she was calm, but and said to me, "Can you please help me?" And I spoke to the other nurses, and they're not listening. I'm on 30 milligrams of oxycodone twice a day. They've only been giving me 10 a day. I feel like I'm withdrawing. I've been doing this for 8 years. So I tell her I'll address it. I go and I don't say what the previous nurse said that left at 11 o'clock. They're not going to do anything at night. So you're going to have to wait till the morning. That is not what we do. So I looked in the patient's home medications and saw that indeed her home medications that she has been on 30 milligrams, and she actually had an additional 15 milligrams of oxy for breakthrough pain. And in the ED note, it did say continue the patient's home regimen of 30 milligrams, such and such, such. So I did contact the overnight doctor, explain the situation, tell him it was in the MAR. He said that he would put in, of course, didn't want to do anything at night because maybe they had a reason for that during the day. He put in for a 10 milligram oxy one-time dose, and I asked him if I could give him the 5 milligram PRN. So she was happy with the 15 milligrams till we got till the morning. The point of this is the patient was actively withdrawing, which could have caused seizures, which could have caused death, because people couldn't have taken literally 5 seconds it took me to go to the home medication recommendations and see what the patient was on. So reconciliation is important. The medication list should be communicated to the next provider and placed in an electronic chart. And on discharge from the facility, the patient should be provided with a complete list of medications to be taken. And that's an opportunity for the patient to become involved in the plan of care and say, I don't want to take this, or, oh, I have this at home, because their home dose might have changed. So if they say, oh, yeah, I have this, and you would say, well, you were taking 10 milligrams and this says 20 milligrams. So you need to speak with your pharmacist. So I just kind of want to reiterate that point. Medication education, it's important that we make sure that we're educating patients on in a way that they know how to understand. So if there's a language barrier or an age barrier, or they don't know how to read, which are all factors, okay, you need to make sure that they're receiving their education in in a way that they can receive it and make sure that they're, verbally able to tell you that they understand the medication and repeat back. And if it's a demonstration, like if they have to go home on Lovenox shots, you're going to teach them and you're going to actually have them demonstrate that back to you. Minimize the potential errors. So you should know the name of all the medications, how they're supposed to be taken, know the side effects, use the correct measuring device. That's important too, because, for example, if you tell somebody to take a teaspoon of Tylenol, but they don't have the correct measuring device, they might just be using the spoon in their cabinet, and it's not going to accurately do that. So making sure that you understand that it's important that they have the right device. Okay, I can't believe it's 10 o'clock already. Okay. Does anyone have any questions before I actually move on to the video? Because I'm afraid we're going to run out of time. Stephanie.
Yeah, just in reviewing how you would document an error. So is the first step to always report it and then call the provider, or is your first thing to just go ahead, call that provider first and then report it after that? I was just confused on if there is an order, if it's a case by case thing.
Yeah, that's a great question. It's a great question. That's kind of, why I mentioned it. So if it's a medication error, like well, for example, for the case of the insulin, right? You push that insulin. It's already documented because she scanned it. She documented that she gave it already. Do you know what I mean? So then her first response would be to call the doctor. She wouldn't wait. She wouldn't like start writing down interventions. Like when you do a medication error, you should report that immediately. You should report that immediately. Because if you're giving insulin, for example, like her case, like that's not going to work instantly in the next 5 minutes. I think it takes 30 to 60 minutes or 30 minutes to kick in. So so I guess there's never really any black and white answer in nursing, as you guys are learning. But I would say that if you have a medication error, you would report it immediately and then document. Did that answer your question?
Yeah, thank you.
Yeah, you're welcome. So this is a really good video. I really wanted to share it with you. Please pay attention as you go and write down on the errors that could have been avoided, the things that stuck out for you. This is something that really happened. And I think it kind of ties in everything that we talked about. Stephen, you have a question?
Yes. The incident report, is that accessed from the system itself, the computer system, or is that a separate paper item that
Yeah. Well, depending on where you are, but in this day and age in the hospitals, you would definitely it would definitely be in the system. So we at Yale, we have something called an RL solution. So you would document in your note what happened, but then you'll actually have to go to an incident report, and it will give you the questions. It'll say, where are you? What happened? What type of event it was? And there'll be drop down boxes, and you'll be like, it's a fall, it's a medication error, it's professionalism. And you would click that and then fill that out. And then it would say who was involved, who was there. It would direct you to fill out all that stuff. I know I went through those slides quickly. So just remember, you want to know the difference between sentinel event and safety event. You want to know about medication reconciliations. You want to know about the variables that could happen that harm a patient. But I feel like we covered everything. But if you certainly have any questions, certainly reach out to me. And I just want to, any other questions while I'm trying to find this file? Go ahead, Megan.
Did you say for when you're pulling the narcotics out of the Pyxis for for a regular like blister pack, like pills, you would not need a second nurse, but for the liquid you would?
Correct. So if I was pulling like a pill form, like an oxycodone, it just asks me to count it and then I put it in. But if I was giving a medication that I needed to waste something, I would need a second nurse so they can watch me waste it. Because obviously, people steal narcotics. If someone would steal that, you know what I mean? Steal the leftover. Does that make sense?
Yeah. Thank you.
All right. Any other questions before I share the video on any clarification of anything I said? All right. I'm going to mute this. I'm hoping, Fallon, if you could just text me and let me know that you can hear and see this, and we'll watch it together. I have to mute myself. Oh, hold on. I'm going to mute myself before I do that.
get into a top tier school versus a lower tier school. Trust me, it's not what you think. Hey everyone.
We had seen a newspaper article about a procedure for a condition called pectus excavatum, which Lewis had. It's a congenital condition that is fairly common. 1 in 200 to 1 in 400 children have it. And the sternum doesn't grow straight, so the chest has sort of a concave appearance. So it was a cosmetic condition for him. And we had seen this article saying that there was a new minimally invasive, very safe procedure to correct it. When he went into the hospital, he was slightly dehydrated. He was not producing urine. And after his surgery, he was prescribed a very low IV drip, something more appropriate for a small child than a 15-year-old boy, certainly not for a 15-year-old boy who was already low on fluids. And we could not get those orders changed. Finally, a pharmacist found it, and there happened to be a very receptive nurse who was a knowledgeable nurse. Most of them were very young, and they were not going to challenge anyone. But this was an older nurse who really knew what she was doing, and she and the pharmacist got the orders changed. For his pain, with hydromorphone and bupivacaine, and he had, for an adjunct medication, IV Toradol every 6 hours. The narcotics were up to, very high levels, sort of dangerous levels for somebody who was opiate naive. And then the ketorolac, which they kept giving, and it seemed to really have no effect on the pain. So he went in for surgery on Thursday. It was Friday afternoon before we got the fluids regulated. Saturday, he was still, he was sweating, he was itching, he was nauseated. He didn't eat the whole time he was in the hospital. At 6:30 Sunday morning, which was half an hour after a Toradol injection, he was suddenly just stricken with this excruciating pain in his upper abdomen, quite a different place from his chest pain. The nurse came running in. She was just leaving the shift change, and she was quite alarmed. And she sort of ran out of the room. And then a few minutes later, she came bustling back in and said, "Oh, it's nothing. It's just constipation from the narcotics." That was the diagnosis that stuck through thick and thin, through every sort of evidence to the contrary. That was the diagnosis he had. Over the course of 30 hours, he continued to deteriorate. He became septic. He exhibited signs of shock and dehydration. He was fairly obviously in bad shape, and no one did anything. Monday morning came, and when they came around to take Lewis's vital signs, he had no blood pressure. And there was just the assumption that couldn't be right, because how could a healthy child in for elective blood surgery have no blood pressure? They took his blood pressure 12 times with 7 different cuffs and machines. So they tried to take blood, and they couldn't. There wasn't much blood there. They were trying to squeeze and wring his arm to get some blood out. While they were doing this, he looked over at me and he started saying something I couldn't understand because his words were slurred. And he said, "It's going black." And I said, "What?" And he repeated it, with great difficulty. I just stared at him. I didn't know what to do about somebody saying something like that. And then suddenly he just arced into cardiac arrest. his body went at all angles and his eyes were staring. And he was dead. One of the things that people don't talk about because it's so personal is what happens afterwards. The effect on families. My daughter's childhood ended that day. She was 10 years old. She lost her parents at the same time as she lost her brother. We had one of those houses where all the kids came, all the teenagers came. Suddenly, our house was silent. And that's just part of it. It goes on and on. It echoes through the generations. Every time my daughter reached a milestone, it was a sad milestone. When she turned 18, we all cried because we knew who had not turned 18. I think that one of the big problems with what happened to Lewis was that people were following guidelines and protocols and were not looking at the patient. All the way through, there was a plan, and the plan did not include a complication. Patients need their caregivers to look at them as individuals, is the first thing. They need their caregivers to take their symptoms seriously, and they need their caregivers to research the medications that they're on. It's not just not to make assumptions. If someone is exhibiting a symptom, you need to find out the correlation of that symptom with their medications. To me, the overriding problem is just the lack of respect for the power of medications. People really don't, providers don't realize, and patients don't either, just how much harm a medication can do.
Okay. All right. So I thought it was really important to watch that video. We have a few more minutes. I asked for a little bit of time, so we're going to end at 10:25, and then you guys can have a 10-minute break. So I wanted to, before I hear your feedback on that, hopefully what we had discussed in our lecture and what we have been discussing was resonating with you as far as making sure that what's the dose of a medication and what side effects are of the medication. And it is totally okay not to know because we can't know everything, right? I don't know everything. But when I feel as a nurse like there is something wrong, especially when you're a new grad, it can be very intimidating. But if you feel like there's something not right, you need to ask questions. You need to, advocate for your patient, and you need to argue. And it seems to me like a lot of things, shockingly, I don't know how somebody gets that sick, honestly, with it not showing up in the lab values and it's not showing up in the blood pressure. Like somebody doesn't have, doesn't lose 40% of their blood volume in their body. And nobody recognize it before it gets to that point. So it'd be interesting to know what the vital signs and lab values were in this case. But something you should know before I get your feedback is that Ketorolac is an NSAID, and the side effects, the side effects of overdosing on that medication are nausea, vomiting, epigastric pain, and gastrointestinal bleeding. And he had all of them, and the signs were there. And again, remember, we talked about how we need to be very careful about children and dosing. So who would like to just start off with telling me, Ryan, about the bloody kept going out? Did everybody have the video, the voice going out?
Yeah, I don't know if it was just me, but it kind of kept skipping in and out,
Oh,
in and out.
I'm sorry.
I kind of heard what was going on, but I'm not 100% sure.
I'll repost the PowerPoint with that link so you can watch it. Anyone
Okay,
would
thanks.
like to comment on the contributing factors? Nicole? Or sorry, just got here. Somebody else? Brittany, Greenleaf? Anyone talk about any of the contributing factors of what went wrong? Anyone else? Jessica, go ahead, Jessica.
She mentioned that like a lot of the nurses were young and new and they were afraid to challenge any like order, so they just like did it regardless. And I feel like I would do the same thing, like especially new.
Yeah.
So that's definitely like was a factor.
Yeah, but that's why we're having this conversation, right? This is why I'm showing you the video, because I want to educate you on the fact that you are going to be put into these situations, like I was, and I made that error. But hopefully, that's why there's such a push for having our nurses come out and teaching them how to critically think. It's why it's so important. Okay, so that's why we're emphasizing that. But absolutely, any other contributing factors or comments anyone wants to make? Stephen?
I just have a question in this situation. Do you notify the provider first, or or is it by rank? You go to the charge nurse and you notify the provider simultaneously, or what would be the protocol?
Well, again, and I know you guys like that first question. I personally would have called the code. If nobody's listening to you, if your patient is in front of you and they are sunken and they are abdomen and they are in excruciating pain and it is a child, I would call a code if nobody is listening to me. There was or rapid response. There was, and if I'm wrong, then I'm wrong. It doesn't matter to me. But I'm saying that with the wisdom of seniority. But I'm letting you know that I'm telling you that you have the right to do that. So I think early on in the video, it had said that an attending had not seen this child. The problem was that everyone was under the thought process that this was a cosmetic surgery. And as the mother said, nothing was going to plan. Like they expected it to go to a certain plan and it wasn't. And people were making excuses as to why it wasn't. Oh, he's constipated, and everything. But how could he be constipated? He'd only been there for 3 days and he hadn't been eating. So yeah, to answer your question, you call the you have to just keep arcing it up. You tell the charge nurse, and if she's not listening, you go to maybe then you go to the attending, and if the attending isn't listening, I mean, at some point someone's got to say there's a fire, but you just have to just keep arcing up your concerns. Who else wanted to comment? All those kind of went up and went down. All right, so a couple things that I will just point out to you that initially right away, what the mother was saying that was that the patient came in dehydrated. He shouldn't have been, the surgery should not have been performed unless his sodium level was correct, right? So it sounds like he was hypernatremic because he was dehydrated. So he wasn't getting the fluids off right away. He wasn't making urine. That's a huge red flag. I mean, you're talking about kidneys. Remember, that's the filtering system of your body and it's not working. That's really bad. So, that wasn't working. He was also on hydromorphone. So he was on a strong narcotic. And again, we're talking about children. We're talking about, he continued, I think she said that he continued to get the ketorolac. So he was getting this pain medication and it wasn't working. So again, what did I say during our slides? When you give a patient a medication, you need to assess. And if you come back and the patient's still in pain, then the documentation and the phone call to the doctor is, I've been giving this patient pain and his pain is 10 out of 10. He is not helping him. It has not helped at all. But instead, they continued with the ketorolac. They didn't discontinue it. And that's what he died of. He died of an overdose of this medication that never even helped him in the first place. They were missing signs and symptoms of shock. I can't imagine. He was listless. He had to be tachycardic. He lost over 40% of his blood volume in his belly. There absolutely had to be signs of that. That did not just happen, out of nowhere. So she had talked about the unwillingness of some of the nurses to challenge the staff. Another thing I wanted to point out was when the mother said that the nurse came out and said, oh, he's fine, it's constipation. We absolutely do not have the right to make a diagnosis. And then the nurse said, well, that continued on, that diagnosis continued. Nurses don't make diagnoses. An abdominal scan should have been made. If you really think that this patient's that constipated, then an abdominal x-ray, as a nurse, you would have said, this patient's in excruciating epigastric pain. His abdomen is distended. I really think we need to do an abdominal x-ray. And it's certainly within your right to do so. And if nobody hears you, again, you need to arc that up. lack of situational awareness, that the patient was continuing to decline. I mean, it was clear he was declining, and nobody was doing anything. So failure to escalate, failure to rescue. And if someone is exhibiting symptoms, they need to find out, why that might be. And that goes back to the overdose. So I know I threw a lot out there with you on that video, but it speaks to the right dose. It speaks to the right reason, the right assessment, recognizing that a medication is actually doing harm, understanding that children are extremely vulnerable and they're not going to react to medications like anybody else. These are all important things. And this could have been an older patient as well. Oh, I'm sure they did sue. I'm sure they did sue. I hope they got $100 million. There was definitely reason to believe that there was many errors, many errors that happened. A lot of things fell through the cracks on that. And again, errors happen. Errors happen. And that's to err is human, and that goes back. But in this case, it just seemed that one after the other. The fact that attending never saw the patient. It's heartbreaking. Julianne, do you have any comments?
Yeah, I just, I'm not disputing errors, but I noticed that there's this incredible fear to speak to physicians and other nurses that are senior.
Yeah.
That's a culture. That's a huge problem, that we're not doing something because we're afraid to talk to someone, and that's created.
Correct.
Why?
Which was why you're absolutely correct. Which is why it goes back to our last conversation. It came out to err as human. That came out 20 years ago because so many people were dying for fear of repercussions. Was 90,000 deaths a year to 7,000 because of medication error. So it did improve. The culture did improve. But now, what we were talking about last week, is that going to set us back? It's all about empowerment. It's not everywhere. And it's, you need to belong to an organization that empowers you to do so. I don't know where this happened, how many years ago. I mean, she looks like an older woman. This looks like it might have happened about 20 years ago, around that time. So, I do think that it's definitely, better. I feel comfortable and safe reporting it. We report it all the time where we are. But like I said, that's why this that Rhonda Vaughn thing is just so shocking across all the healthcare systems, because again, this looks like it might have been happened about 20 years ago. But yes, people need to be empowered to step up. So you need to make sure that when you're looking for jobs, you're in a position. And just like that nurse I told you was talking to myself and one of your colleagues about that insulin error. I mean, can you imagine anything more horrifying than a senior nurse telling you not to worry about it? This is why I'm teaching you these things. You need to really come out with the knowledge and be empowered. And, you're never going to get in trouble if you err on the side of caution. Sonia, go ahead. Or anyone else who wants to comment or question. Did that answer your question? Or that wasn't really a question, but comment on it. Yeah, I know it's scary. And, you're entering into a scary field. Which is why the discussions always are going to be around the value of nurses and what we have to be put through and the stress level that we are in. I mean, it's a very serious thing that you are embarking on. And it's so important that you protect yourselves and your patient by following those rights. They're there for they're there for a reason. I'm horrified on my own practice when I see nurses, young nurses and older nurses, that have just let the fundamentals of basic safety practice slide. And it's because of complacency, and because I just don't think that they have the real understanding that any patient at any moment, something can happen to them. Look at that patient that I talked to you about, that I came in and the blood pressure was 72/40. There was no reason for that nurse to think that he didn't come in. Actually, he came in hypertensive. So there was no reason for her to think that was even an issue. So it wasn't even on our radar. But there's orders there for a reason, and we have to follow them. Any other questions, comments? Interested in your thoughts about this? All right. Any other questions about the slides? Like I said, I know I reviewed them quickly. It's because I really wanted to get that video out to you, because we had been talking about the different situations that happen. So you can certainly email me. You're going to get a 10-minute break now, and then you are going to, yeah, thank you very much, Samantha. You are going to then have a 10-minute break. And then after your lecture, we're going to be doing test review. Kara, you have a last question you want to ask?
Yeah, I have one last quick question. Can you just quickly go over the sedation scale one more time? Like
Yep,
how
absolutely.
how would you rate the score, I guess, is my
Yeah.
question.
Yeah, sure. So it's right there. So this checklist would come up. Oops, this checklist would come up, and you don't necessarily need to know the score, but know what you do. So if the patient's awake and alert, then you know you can give the medication. But the documentation in the chart would be a 1. So it actually gives you, you'll click it and it will come out. 2, slightly drowsy. So the patient's, awake and alert, and they're a little drowsy, but they're fine. But they're still having like 8 out of 10 pain. I also want to make sure that you know that anytime you give a narcotic, you should always be pre-assessing their respiration level, right? So you're documenting their pain, and you also want to document, the respirations, because we know that in larger doses, narcotics can cause respiratory depression. That's the big thing. That's what I did. I overdosed my patient. His respirations, if I had bothered to count them, which I did not, were probably already like a 10. So it's important that we know that when we're giving a medication that we're assessing, we have to do our assessment pre and post, just like we assess post pain. And then, of course, in my case, the patient was like awake enough to talk to me. He talked to me, but as he was talking, he was like falling asleep. He was like groggy, and he didn't even tell me he was in pain. I just gave it to him because they said I have to give it to him every 6 hours, and this is what he's been on. So I just gave it to him. I don't know what I was thinking. And then, of course, if I can't wake my patient up and he's been on narcotics, we're gonna call our team, perhaps give naloxone, that kind of stuff. Denise, go ahead.
I didn't mean to raise my hand. Sorry.
That's okay. Did I answer your question? Previous one about the scale?
Yeah, that helped. Thank you.
Yeah. So the number's just going to go in, but just make sure that you're aware of what you would do. This is going to be there for you. But for the case of our learning right now, I would like to know that you recognize that this is not a good situation. So I'm going to stop the medication. I'm going to notify the provider, and I'm going to continue to monitor his respirations and his level of sedation.
Okay. Thank you.
All right. Yeah. All right. Anyone else? Okay. So 10-minute break. Come back at 10:35. You're welcome, Stephen. And then, and that's it. And you can email me any questions you have. Great. You're welcome. You're welcome. You're welcome.
We have 1 minute, then I'll get started. All right, we are on. So this morning we are going to get a further in-depth look at hypertension, as it was a exemplar that was touched upon last semester with the concept introduction of tissue perfusion. I am going to go ahead and share that case study that was posted in Blackboard, a reflect activity as part of the hypertension module. And this is how, discussing these case studies, we're going to present and discuss a lot of the material in detail that was presented in the PowerPoint presentation for hypertension. So let's take a look at this case study that we have here in front of you and kind of digest and pick out some of the situations here that are identifying, I'm in 49 something or another. I just saw a whiz by me here. You're 49 and you can't see that, huh? What's that gonna identify for those over 50? Oh man, oh man. You can actually control it on your own computer screen as well. Okay, but hopefully that'll help regardless. Thank you, class, for sharing that information in detail. So let's take a look at our client here, Melinda, who's 42 years old and primary hypertension. What is primary hypertension? What does that identify? I'm looking for chat box.
Isn't it undiagnosed or undiagnosable, no known cause?
No, because it's
I mean,
diagnosed. It's primary hypertension. There's no known cause. Correct.
there you go.
No identifiable cause or reasoning for the hypertension, as opposed to secondary hypertension, which identifies what? What's secondary hypertension mean?
That there is
Underlying cause.
That there is an underlying cause, or there's a reason for this elevated in blood pressure that we are seeing. So yes, an identifiable cause, an underlying cause. What are some, and go ahead and put it in the chat, what are some reasons or causes of secondary hypertension? Okay. High sodium diet, that's a risk factor. Those are contributing factors. Obesity is a risk factor, right? Pregnancy is definitely a secondary or a cause for secondary hypertension, right? Or that increase in hypervolemia with the pregnancy, hormones, cardiac problems. Exactly, like coarctation or narrowing of the aorta. Those are secondary reasoning. That is contributing factor is hypertension. RAS dysfunction. And RAS dysfunction identifies a problem in what system, Ryan? Kidney disease. So there you go. An underlying cause is renal disease. You know, renin, aldosterone, those are all hormones that are related to urine, urinary output, fluid volume, right? Think about blood pressure control and the intricate role that the kidneys have in it, right? Blood pressure is cardiac output, right? And cardiac output volume has a lot to do with the measure of cardiac output. And what affects volume? Kidney function. Fluid balance control, renin, right? So that's an important factor to remember as we continue our discussion. And then we think about medications that help control blood pressure, right? Renin, aldosterone, and ACE inhibitors, and how they stop that process of releasing the converting factors, converting angiotensin to all those renin angiotensin models, right, to help control blood pressure. Let's see, what other secondary factors? Hormone disorders like hypothyroidism, absolutely correct, is another big one. Endocrine, because we've identified already several hormones that contribute and deal with blood pressure control. We identified renin, we identified aldosterone. What's another hormone that's intricately associated with blood pressure control and fluid volume? Antidiuretic hormone, very good, or ADH, awesome. Having that understanding, again, that foundational knowledge helps you better understand to be able to critical think what you see in front of you with your patient's case scenario. Okay, drug use, because of the effects of drugs on the body. Vasoconstriction is another contributing or cause secondary hypertension. All right, so let's see. So we know our client here has primary hypertension. She's married. You have some demographic information in detail here. Why do you think that information is important? She's married. The partner has children, she has children. Why is that important or significant to identify? Stress, absolutely. Life stress, absolutely, because stress, we know, is a major risk factor that is associated with hypertension. All right, what else here identifies contributing or risk factors that place our client at risk. Does she have diabetes? Yeah, that's fine, David. She has a family history of diabetes, right? Which increases her then secondary risk factors, comorbidities. Oh, snap. What are you snapping? You got to read carefully. Her mom has diabetes. What are her known risk factors? Inactivity, that's right. She does a lot in her car. We know, and it's been evidence-based practice proven that inactivity contributes to many comorbid situations, right? Inactivity can lead to or contribute to hyperlipidemia, right? What is the recommendation as far as activity goes for healthy lifestyle? What is the recommended activity level for at least 30 minutes every day or most days, right? Definitely a minimum of 5. If they can do 7, great, but at least 5 days and for 30 minutes a day. Absolutely, because inactivity is a major leading contributing risk factor associated not only again with hypertension, but with diabetes. She has a family history of diabetes. Hyperlipidemia. Why is hyperlipidemia important or significant as it relates to hypertension? What's the correlation? Atherosclerosis. Awesome, Ryan. And it clogs the arteries. Yes, atherosclerosis. So we're narrowing that lumen of the blood vessel, the arteries, which is what is being measured in blood pressure management or control. So there goes your blood pressure, right? Your cardiac output times your vascular resistance. So vascular resistance is going to be impacted by the diameter of that blood vessel, that lumen, which if clogged with fatty deposits and plaques is going to increase blood pressure. So that's awesome. Very good. All right. So let's see. What other risk factors here? So she lives in a car. She's been prescribed several antihypertensives. So give me some different types of antihypertensives. Usually what might most clients be started with if they're going to be started on medication therapy? Diuretics, very good. And some types of diuretics are your loop diuretics, your thiazide diuretics. We know that those are potassium wasting, as we had a whole big discussion previously. You were tested on it, potassium wasting diuretics. So it's important to monitor fluid and electrolytes and their potassium levels. You have the potassium sparing diuretics, such as spiralaldactone being one of those. Thank you. Other medications are your ACE inhibitors. And thank you, Sonia, for identifying what most ACE inhibitors are going to end with. So many of them will end in pril, right? And I might have mentioned in the past that I think of A for ACE inhibitors as to help me remember or take a look at, oh yeah, that April, that's an ACE inhibitor, right? Your calcium channel blockers or your CCB, calcium channel blockers, which are another line of defense. Calcium channel blockers are pretty often going to be prescribed along with your diuretics to African American populations because it has been found that the ACE inhibitors are not very effective or therapeutic in treating that population. Within your resources in Blackboard, I did post the link or the actual PDF file of the American Heart Association and their guidelines related to hypertension. That is a very useful tool, a very good toolkit to have in your toolbox. All right, those guidelines are from 2017. I have looked to see if they have been updated, and as of yet, I have not been able to find. I don't think that they've been updated yet. But that is very good information and detail that you should be familiar with at this point in time. It covers from the very simplistic foundational, right? How to appropriately measure a blood pressure cuff, right? Appropriate size fitting blood pressure cuff, sitting, feet flat on the floor. Obviously not after the patient comes in, all huffed and puffed because they just arrived to their appointment. It identifies white coat syndrome, which oftentimes your elder population or even your populations that are at high risk for hypertension, right? They're going to come into the office and they're already fearful and tense because they're going to have their blood pressure measured. My husband is one of those, right? Oh my God, I'm going to have my blood pressure measured. I need to take a sedative just to have this done. Because of the potential risk that if that blood pressure reading is elevated in the office, they might be going into the next step in the process for treatment. All right. It identifies the parameters as well as your textbook does the same in the very beginning part of the hypertension discussion. The classification of blood pressure, whether blood pressure is elevated versus stage 1 or stage 2 hypertensive. That information in detail is also found in the handout. It was prepared for you in Blackboard. It is on page 1247, but you should be familiar with those parameters. All right. Essentially, desirable blood pressure is below 120/80. 120/80 is no longer a desirable blood pressure. It should be lower than that. Okay. Mass hypertension. Yep, mass hypertension was something I never heard of. Anna, very good. Correct, because there's underlying factors, fear. All right. All right, so let's see. Moving along with, she's on captopril. We know what kind of medication is that captopril? What is that? It is an ACE inhibitor, which is one of the classifications of antihypertensives. We didn't mention them all, but there's also beta blockers. That's another classification of antihypertensives. There's vasodilators. Vasodilators are pretty typically going to be used in hypertensive emergency or urgency situations where someone's blood pressure needs to be lowered rather quickly as opposed to over a gradual period of time. Okay. Hydralazine is one of those examples of a vasodilator. Again, a prototype that was identified in your handout. Nitroprusside is another one to help lower blood pressure rather quickly. And even with rather quickly, it should not be lowered too quickly because that can decrease tissue perfusion to the client and places the client at greater risk. So anytime your client might come in a hypertensive emergency situation or crisis, and this terminology we'll get into further discussion, oftentimes they are used together. Hypertensive urgency or crisis, your patient comes in with a blood pressure of 180/120 or higher. That is an urgent situation that needs further management and evaluation. If that blood pressure reading is associated with manifestations of affecting target end organs, that hypertensive urgency now becomes a hypertensive emergency where that blood pressure does need to be lowered rather quickly, should never be lowered drastically or any quickly than over an hour. You don't want to lower that mean arterial pressure, which I know you spoke about, learned about with Professor Faraday's information and detail regarding shock, right? You don't want to lower it any quicker than 25% of what it is over the course of an hour, okay? So hydralazine is one medication that could be identified for someone that does come in with target end organ manifestations. What's that mean? Target end organ manifestations. What are we looking for to identify if there is target and organ manifestations. Absolutely correct, Stephanie, where now we have other organs that are being affected by that hypertensive urgency or emergency situation. Think about what is happening in a hypertensive situation. Vasoconstriction. Vasoconstriction means decreased blood flow. Decreased blood flow means decreased perfusion to organs. So an example has been identified here is renal, the renal system being affected. So you're looking at urinary output, right? We know that minimal urinary output is 30 mLs in an hour. So you are checking very good for oliguria and urea, right? But what if it's not to that extreme, right? How do you know if the kidneys are appropriately functioning? What are you assessing for aside from urinary output? ESR, glomerular filtration rate, BUN, and creatinine. Absolutely correct. So you need to be aware of what those labs are identifying and what the normal parameters are, especially as it relates to renal function. So one target organ, renal function. And I believe I saw here then affecting the brain. So manifestations indicating brain involvement. Level of consciousness, that's the extreme, right? How do you assess for level of consciousness? What are you assessing this client for? How do you assess level of consciousness? Alert and oriented? Are they confused? Are they lethargic, right? What's their speech like? Is their speech slurred? Arousability, awesome. So that can identify decreased perfusion to the brain, or maybe even beyond decreased perfusion. Now, there's so much vasoconstriction and pressure that build up within those blood vessels feeding the brain that maybe you have now like micro little aneurysms, which potentially then can mean bleeding into the brain. Cerebral edema, correct. There's only so much space that that skull can hold, right? So if there's bleeding and swelling into the brain, it's going to affect level of consciousness, mentation. Heart, very good. So heart manifestations could include what? What might be some of those manifestations that your client might come in if they're in a hypertensive crisis situation? Elevated heart rate, pretty universal for many of the things that we see. Chest pain, very good. Angina, absolutely correct. Target organ manifestations. What is another major organ that is affected with hypertension and can be manifested? Lungs, the eyes, absolutely correct. The eyes. Vasoconstriction to the retina can lead to papilledema. So what are some manifestations that you think your client might come in reporting? Blurry vision, correct. Changes in their visual field. Very good, very good. So those are your hypertensive crisis or emergency when there is target organ involvement, all right? If there's an elevated blood pressure, 180 over 120, but there are no manifestations that there is target organ involvement, then the client is going to be managed with antihypertensive medications and be seen for further evaluation. But those that your client comes in complaining of headache, dizziness, blurry vision, chest pain, right? Those are then a further situation of target and organ involvement, and further treatment needs to be done to lower that blood pressure sooner rather than later. All right, so let's see. Even despite taking that ACE inhibitor, her blood pressure is elevated. what precautions are you going to teach this client regarding that ACE inhibitor? So what are some teachings now, or what you need to be informing your client as it relates to the ACE? Dry cough, very good. Dry cough, a common side effect that may be seen with these ACE inhibitors are dry cough, right? And they can be pretty troublesome or bothersome. So that client definitely needs to be letting their provider know if they do develop that dry cough. Absolutely, as with any antihypertensive medication, especially in your elder population. Now, this client is far from being elder, but you definitely want to give information and education on getting up slowly because of postural or orthostatic hypertension. Okay. So what else as it relates to that medication? Is there anything else? There's definitely much more teaching that is associated with this client, but looking at addressing that very first question, main factors are changing in position, that dry cough, and to report any signs of dizziness, right? Want to make sure that that blood pressure is not lowering too quickly, that she's not having an adverse reaction. Definitely the dry cough and reporting that, okay? What else do you want to educate her regarding the medication? Manifestations of potential allergies, right? Allergies to the medication. Anytime a first dose medication is given, you're watching for that angioedema, swelling of the face, hands, lips. Okay. Do not skip a dose. Absolutely. Absolutely. Good point that you bring up, especially as it relates to hypertensive medication, and most importantly for your beta blockers. What do your beta blockers end in? How can you often identify your all-alls? Very good. Your all-alls. Your all-alls beta blockers to help lower blood pressure. What else does it lower? Not only blood pressure, but it also lowers what? Heart rate, correct. So what are you assessing your client for before these medications are administered? Your beta blockers. You're assessing heart rate and what else? And blood pressure. Very good. Very good. There's usually set parameters, right? It depends. Sometimes they might have 50 or 60, depending on the provider, right? So that's important to know. And many medical medication dispensing computer systems identify what that parameter should be, all right? Antihypertensives, especially your beta blockers, should never be stopped abruptly, because that is actually one of the leading causes of why clients come into emergency rooms in hypertensive urgency situations, because they're not compliant with their medications. So that's an important teaching factor. Instruct your client, do not stop taking the medication abruptly. Take it as prescribed. It should not be stopped abruptly, and the potential dangers that it can cause, because many ER visits are related to non-compliancy with medication, okay? That's also an assessment question you want to ask when your client does come in for checking their blood pressure, and you note that their blood pressure remains elevated. Before going ahead and changing the regimen, the provider should know, has this patient remained compliant with taking their medication? All right. And if they're not, identify why aren't they taking their medication, right? Is it because of signs and symptoms of adverse effects or side effects, which I noted some of them here, you know, dry mouth, decreased libido especially in men, right? And those, again, side effects identified on the handout that was provided for you. It is important that your clients are aware of these side effects, how they can help minimize if they have dry mouth, obviously maybe sucking on a hard candy, right? But don't stop taking your medication. All right, let's see. Now your next question here. Side effects, we did that. Also important to monitor, we spoke about renal function. It's important to monitor CBC lab values because it can potentially lower white blood cell count, right? All right. How about as far as electrolyte levels with the use of these ACE inhibitors? What is its impact on potassium? It can increase potassium. Absolutely correct, Stephen. It can increase potassium. One of the effects of the medication is to help limit or reduce aldosterone, which is good, right? Because aldosterone, we know, retains sodium. We don't want sodium retention when it relates to hypertension because we know what sodium retention does, right? That increases fluid, which can then increase vascular resistance because now you have more blood pumping through. So when you have decreased aldosterone or decreased sodium, the adverse effect is you're going to have increased potassium. So making sure these clients are aware not to use any salt substitutes because we know salt substitutes are potassium based, right? And that can increase potassium levels. Now the next question here, if you admitted your client to the provider's office before the ACE inhibitor of captopril was prescribed, what interview questions are you going to want to explore to determine lifestyle factors that could be contributing? We know from the description that she does a lot of activities in her car, right? Diet is huge. Absolutely correct. Tell me more about diet and dietary factors which contribute, can lead to, and are risk factors for hypertension. High sodium diet. What's the recommended? No more than how many milligrams on a daily basis of sodium? 2,300. Thank you very much, Anna. And that should be for a normal person, non-hypertensive, no medical problems. It should not be any higher than 23 milligrams, right? We know that on a routine basis, many of the meals that are consumed already contain 25% of your RDA, so that the average diet is well over 4,000 milligrams, which is totally unhealthy. But for your client that is a hypertensive, their sodium intake should be lower than, ideally, 1,500 milligrams, right? You have that 2-gram sodium diet, which is a reduced sodium diet. That means no adding salt to cooking, no adding salt to the table food already prepared. So the importance of what are they consuming? What types of foods? Frozen foods, fast food, canned foods, right? Activity level, absolutely correct. We spoke about that. Do you drink alcohol? What's the effect of alcohol? Assess how much calcium and potassium they're intaking. Alcohol raises blood pressure, absolutely correct. Does that mean that alcohol needs to be totally removed from the diet? It causes vasoconstriction. Absolutely. Very good, David. No. 1 a day for your female, right? 1 ounce of alcohol, 1 shot, if you will, right? 1 beer. For males, it is higher than that. It could be up to 3 beers. But again, looking at those recommendations, absolutely not. If we talk about stopping alcohol, Sonia, absolutely not, huh? It has been actually demonstrated again that a glass of wine could help relax enough that smooth muscle relaxation of the blood vessels, which can help lower your blood pressure. What else with regards to diet? Absolutely sodium, but what else do we want to take a look at? What else do we have here? Let's see. Fat intake, lipids, correct. Absolutely correct. And for that premise, it is important as we educate and work with our clients with lifestyle modifications, not only related to exercise, but diet is very important. The DASH diet, you should be familiar with. I'm certain you have all heard about that DASH diet, right? What does DASH diet mean? What does it stand for? Ba-dum-bum. What is this DASH diet? Some of you may have seen the Mrs. Dash seasoning in your stores, right? That is seasoning that does not contain any salt, but it is a mixture of a lot of herbs, right? DASH diet is focused on your lean proteins, vegetables. Thank you, Marcin, very much. Yeah, had to that was quick typing, had to look that up. DASH diet stands for dietary approaches to stop hypertension, right? So if you didn't know it before, there you go. That's a fun fact you learned for today. DASH actually means something. It's not just that seasoning that's added to flavor food, okay? Low fat food products, skim milk, low fat milk, correct, right? Limiting fat intake. Again, does not mean it needs to be totally removed, but it is not a major component of your daily RDA. And again, the presentation prepared has information about the DASH diet. It actually has like the My Plate with portions and what the focus is on. Lean proteins, lean meats, fruits, vegetables, nuts, whole grains, and most important, low sodium. Okay. All right, let's see. What else? Can you tell me about your diet? So obviously, if she works from her car, does a lot from her car, there's a lot of teaching that needs to be done with respect to dietary. And the last question, what nutritional recommendations will you make to your client to help control her hypertension? We've spoken about the DASH diet. That would be a major component of it. High fiber, low fat, fruits and vegetables. We spoke about alcohol, an important factor I didn't see mentioned as far as calcium, but you want to inquire what's her vitamin D intake, right? Vitamin D increases the absorption of calcium. Right, so vitamin D has also been found to potentially be associated with an increase in blood pressure. Smoking, very good, Ryan. What about smoking? This client does not identify here in this scenario that she smokes, right?
Don't do it.
Tell me, I'm sorry?
I said, don't do it.
Don't do it. Why?
Because of the arteries. It hardens your arteries.
It leads to plaque formation, correct. Again, narrowing that lumen, vasoconstrictor, so it definitely increasing factor. So does that mean that nicotine replacement is beneficial?
Yes. But it's still better to completely quit. Well, I mean, quitting smoking
you need to completely, ideally, decrease or minimize the cigarettes per day, because some of those nicotine replacements still do contain some level of nicotine in them, right? But if it's going to be an effective tool to help them lower or decrease it, anything to help them decrease, but it's not something that ideally they want to stay on for a sustained period of time. Cinnamon sticks. Interesting. I never heard about that one, but thank you for sharing that, Sonia. All right. So I think that we've kind of hit on her. Oh, thank you. Whose awesome picture is that? Who's the jester?
Oh, I think that's me.
Ryan, somehow I'm not surprised.
It was a former life of mine.
Let's take a look at, I think we have another situation here. All right. Yeah, I'm not going to wear my clown outfit for you guys. All right. let's take a look at another case scenario here. You have another situation where now you have a 50-year-old male. So we've identified a 42-year-old female, a 50-year-old male. What are some high-risk populations associated with hypertension? Oops, let's see what I got here. Got to go back to the chat. Seen more frequently in males over the age of 50. White males, Stephen, where are you? It's more frequently found in the African American population. Absolutely. It's often referred to as the silent killer. Why is that? Why is it referred to as the silent killer?
Because you don't show symptoms right away, and then when you start to exhibit them.
Are absolutely correct. Typically, there are no manifestations until there is that target organ damage. And by that time, it's, as the name indicates, it's damaged. That means that organs have already been affected. Okay, silent killer, they don't know they have it. So that's the importance and the significance of prevention, right? Getting those blood pressure screenings done, because you may not know that you have hypertension, but there are certainly at-risk populations, and the African American population is definitely at a higher risk, as are your Hispanic populations, right? It does affect more white men overall than women, but ethnic or population groups are your African Americans, your Hispanics, males over females. Your Native Americans are another group or population that are at a higher risk. Okay. And hypertension does not discriminate whether rich or poor, so all socioeconomic status, but your lower income, lower socioeconomic status may be seen more frequently. Why is that? It's not so much that it's going to be seen more free. It's correct. Lifestyle choices,
food deserts.
healthcare. I'm sorry?
I said food deserts.
Yeah, food choices, preferences, what they can afford, primary prevention, going to the doctors, having a doctor, right? All factors that contribute. Okay, so this client comes in for a blood pressure screening, which is awesome. He has some headaches. Oh, that's a problem, right? We spoke about that earlier in the other case study, manifestations, affecting now dizziness. He's a truck driver, eats fast foods. We spoke about that. Look at his blood pressure. What stage of hypertension does this client have? Talking about stage as far as classification of blood pressure. He is a stage 2 antihypertensive. Stage 2. If you look at the different stages, stage 3 is 180 over 120, right? Or any combination thereof. Yes, his top number is elevated, right? So actually, he is 182, so he would potentially classify as a stage 3, especially if he does have the end organ manifestations. You are correct, stage 3, right? Look at his height and weight. What do you think we also has as a contributing factor here? Obesity, very good, very, very good. So based on what we see, he also smokes a pack and a half of cigarettes. So we identified that as a risk factor. He's a truck driver, so you know he eats fast foods. Fast foods are generally high in sodium, high in fat. Okay. Very similar scenario in respect to the other one that we did have, except here you have some actual blood pressure readings, other data as far as his height and weight. So obesity, if you can calculate his BMI, that's important to know as well. Overweight versus obese. Lifestyle modifications for this client would be, again, activity, diet, diet. Teaching with respect to medications. All right, you know what? I am going to let's go over some of this information in detail in the event that there might be some factors to continue to go over. All right, so let's see what we have here. Here we go. So again, found in your textbook, prepared for you here as well. Stage 2, 140 or higher. Your hypertensive crisis situations higher than 180 and or a diastolic of 120 or higher. Okay, desirable factors below 120 over 80. Mention what blood pressure is a measurement of. Vascular resistance is important as it relates to atherosclerosis, right? The lumining or thickening of that blood vessels. Cardiac output as it relates to the pulse. Blood viscosity, those are all factors that contribute and relate to increase or changes in your blood pressure. Right? Cardiac output is your stroke volume or how much blood you have pumping through your heart. That's particularly important. I know, again, you spoke about shock, right? Decreased blood volume. So that's where you have decreased blood pressure. Here we're looking at increase in blood volume as it relates to fluid retention, hormones, right? Those are all factors that contribute to cardiac output. And then your vascular resistance as it relates to the diameter of the vessel, the length of the vessel, basic components. A good visual of those factors that do contribute to blood pressure control. We spoke about the renal system and hormones as it relates to blood volume. The nervous system or the sympathetic nervous system, in particular as it relates to that flight or fight hormone, epinephrine, which increases blood pressure. So disorders of the adrenal medulla have a very huge impact on blood pressure reading and control. Pheochromocytoma. OMA is tumor as it relates to a tumor within the adrenal gland, especially that medulla in the adrenal gland, which is where those hormones, epinephrine and norepinephrine, come from. So hormone as it relates to blood pressure management and control. All right, baroreceptors, those are the specialized cells in our body, like your carotid arteries, right, which are sensitive because that's what is helpful also in maintaining blood pressure control. Your chemoreceptors, chemo as they start to recognize and help with your oxygen and carbon dioxide and pH levels. Those are all factors that contribute to blood pressure management and control. That hormone, ANP, right? Blood pressure, sodium, cardiac, measured in your clients with heart failure. All right, so system by system approach, hormones that we've spoken about. So having that, again, foundational knowledge helps you better understand your client and the manifestations that you are seeing. All right, so the hormones as it relates to causes of hypertension, exercise levels, stress we spoke about, right? Your circadian rhythm, Positioning very much, right? Someone has low blood pressure, we tend to lay them flat or a little bit in Trendelenburg, as opposed to if someone has higher blood pressure readings, right? The positioning that you would want to place them in. So your nurse determines that the client has stage 2 hypertension when which of the following are demonstrated? Let's see what we got here. We have a B. We have a B and D. We have an A and B. Anything else? Let's see. I see one person so far that has selected them all. Another person that has, okay, there we go. So it is actually A, B, and D, correct. Again, take a look at the table on page 1247. All right. What is E? What stage is that? Stage 1. Very good. And what is C? What stage is that? Is that normal blood pressure? I can't hear anybody. It is elevated, correct. Desirable, again, lower than 120. We've got 122 going on here. Primary hypertension, we spoke about that. No known cause. All right, and contributing factors. Secondary hypertension, again, factors that we've spoken about. Endocrine disorders, think about the many hormones associated with blood pressure management. Sleep apnea, which can be detrimental to someone's health. So the hypertensive urgency, again, the algorithm that is identified by the American Heart Association for management thereof. You don't need to memorize this. Important factors you need to identify here is what is the difference between a hypertensive urgency situation versus a hypertensive emergency, right? So hypertensive urgency, you do have that elevated blood pressure, but you don't have any organ dysfunction or that target end organ damage, okay? If headaches, other manifestations are found, then you have that hypertensive emergency situation, which is also referred to as a hypertensive crisis. You might also hear it as malignant hypertension, all right? Just some other names that you may hear it referred to as. And as identified, you do want that blood pressure lowered a little bit more rapidly, but not too rapid, because you do want to maintain some perfusion to vital organs, and lowering blood pressure too quickly can potentially decrease blood flow or perfusion to major organs. Okay, spoke about the medications that can potentially be used. Your populations at risk, we identified that in our case study. Risk factors, we spoke about the importance of many of these factors: obesity, race, activity level, mood. So education and information is extremely important. Let's see what other. Your organs, target organs that are affected. So think about manifestations that might be seen as we identified: headache, blurry vision, dizziness, chest pain, numbness or tingling if there is a potential stroke that's going to be associated with breakage in blood vessels to the brain, paresthesias, tingling, clinical manifestations, a good visual of what you might find with diagnostic testing as that heart muscle is working harder because of the vasoconstriction, right? It's a muscle, so that muscle is going to build and thicken and hypertrophy. right? So notice the decrease in lumen, then that we have the blood potentially going through that heart. All right, so think about then manifestations that you might see or hear of: chest pain, angina. System by system and the manifestations that may be seen. We spoke about the importance of measuring diagnostic testing, BUN, renal function, creatinine, glomerular filtration rate. Okay. Diagnostic testing, ECG, important, especially think about that visual you saw of the heart. So it's important to have a baseline ECG readings. Measuring electrolyte levels, the importance and significance again of potassium and its effect on the heart and heart muscle. Think about risk factors that we identified: diet, obesity, high fat diet. So it is important to monitor your clients' lipid levels, cholesterols, which you should have a good working knowledge again of normal parameters. Diagnostic testing, exams to check renal function, intravenous pyelogram. They are injecting a dye to take a look at perfusion through the kidneys. So important to ascertain and determine if your client has any allergies. So the different identifications and classifications of the medications we identified within the case studies that might be used: your thiazide diuretics and your loop diuretics, again, potassium wasting. Your ACE inhibitors, many of them are going to end with the prill. You do have a table within your book, which is important information in detail. It starts on page 1255, which identifies these classifications and nursing implications. So I do encourage you to take a look at and review that information in detail. Your beta blockers, many of them end in the olols. Again, should not be stopped abruptly. You need to be measuring and assessing their parameters. Your emergency medications, such as your hydralazine, nitroprusside is another one. Those are your vasodilators, which are going to be used in your extreme hypertensive urgency situations and emergencies. I notice my colleagues are coming into the room as we are preparing, going to go through exam 3 overview for you. So much of this information and detail we did touch upon in the case studies that we went through. It is important that your clients, if they are demonstrating an increase in blood pressure and definitely diagnosed as hypertensives, that they have routine follow-up care, right? So someone who's normal tensive, yearly checkup is fine. We identified the importance of that primary prevention, right? Blood pressure screenings. But someone who is diagnosed with hypertension is going to need more frequent monitoring of their blood pressures. You know, having it checked once a year is not going to work for your clients that do have and are being treated for hypertension. So again, the American Heart Association and their guidelines, and this information and detail is found within the toolkit that was included in Blackboard for you. Okay. Some of the potential side effects that we did address and identify, which can contribute to much of the non-compliancy associated with medication intake, which can then lead to emergency room visits because they are now coming in with hypertensive emergency situations because they are not taking their medications as ordered. All right, so much of this information we have gone through. I'm going to change gears here now. If you do have any information, as